Hello and welcome everyone to the Lightning Talk session. My name is Fatima Torabi, a data scientist at Swansea University. I'm honored to invite you all to hear our 5 selected projects across HDR UK community, led by Yelena Beswick, James Liley, Cor Mankowitz, Claudia Frontier, and Daniel Thompson. Just to give you a bit of structure of the session, each talk will last exactly 4 minutes and we are going to have a winner based on your votes. So please do ensure to submit your live vote at the end of the session. Now on to our first speaker, Yelena.
Is the UK Biobank COVID-19 serology study. Just briefly, I'm going to give an overview of what UK Biobank is for those that are not familiar. It's a resource for scientists to study the causes of disease to better understand how lifestyle, genes, and the environment interact to cause disease in some people but not others. I'm not sure, would I be able to get the next slide, please? Approximately 500,000 adults aged 40 to 69 were recruited between 2006 and 2010, and they provided detailed information on their lifestyle and medical history through questionnaires and provided biological samples. The participants also provided consent for linkage to routine health data. Next slide, please. And now onto the study. So in response to the coronavirus pandemic in May 2020, UK Biobank set up a new study involving 20,000 individuals. That was 10,000 existing participants and 10,000 of their adult children and grandchildren. This was done in order to increase representation across all adult ages. So all participants were asked to provide a blood sample and complete a symptom survey on a monthly basis for 6 months to test if antibodies to the coronavirus that causes COVID-19 were present. The aim of the study was to investigate the extent to which previous coronavirus infection varied across the United Kingdom by age, ethnicity, and socioeconomic deprivation, and the study also aimed to investigate the persistence of antibodies over a 6-month period. Next slide, please. So during the study, just under 19,000 participants returned a blood sample, and of those, 9% had at least one blood sample which indicated a past infection. So we can see that the percentage of people with a past coronavirus infection had increased during the study from 6.6% in June to just under 9% in November, which matches up well with the second wave of the pandemic. We found that the rate of previous coronavirus infection varied substantially across different regions of the UK, as well as by age, ethnicity, and socioeconomic deprivation, being higher in those who lived in London who were under 50 years of age, of Black or South Asian ethnicity, and who lived in more deprived areas. And we also found that 6 months following infection, antibodies were still detected in 88% of participants who had detectable antibodies in month 1 of the study, and their date of infection was known. So the results of this study were reported to the Department of Health and Social Care on a regular basis to inform their response to the COVID-19 pandemic. Next slide, please. So all of these data will be incorporated into the UK Biobank resource and made available to researchers, together with all other data that UK Biobank holds, such as genetics and primary care, which will enable further vital research into COVID-19. We're also currently undertaking home antibody testing of all UK Biobank participants, where those that are interested are sent a home testing kit to see if they have antibodies to the coronavirus. Those that have antibodies and are vaccinated will be invited to provide a blood sample, which can be used to determine whether they have antibodies as a result of past infection. So the results of the self-test study are being used to identify participants for a COVID-19 imaging study that's ongoing. So far, 850 participants have attended, about half of whom have had COVID, which means we'll now have images for participants before and after COVID, which will allow researchers to look into the impact of COVID on internal organs. So as I mentioned, all the data will be made available to the research community via application to UK Biobank so that we can all investigate the long-term health effects of COVID-19 with the aim of improving human health and patient care. And I'd just like to finish by thanking all UK Biobank participants for their contribution to the study and their relatives who contributed to the serology study, as well as the Department of Health and Social Care for funding the study. And I'll now pass over to James. Thank you.
Thank you very much, Elena, and good morning all. I'm James, and I work at the University of Edinburgh on a tool to predict the risk of emergency admissions in the Scottish population. This is being developed between Public Health Scotland and the Alan Turing Institute, a network of UK researchers in artificial intelligence. In 2005, NHS Scotland made a series of recommendations for the future of medicine in the country, including calling for an integrated effort in preventing medical emergencies. An emergency constitutes a breakdown of health and a transition from primary preventative medical care to secondary curative care. Reducing admissions to emergency departments is good both for the individual health and for efficiency of the UK health system. Such efficiency is especially important in times of healthcare stress, such as during and after the current pandemic. In 2006, a project called Sparrow was founded to address the same. For a given patient in a given time, it estimates the probability that they will be admitted to a hospital in the subsequent year, on the basis of electronic records routinely collected by Scottish hospitals. Sparrow scores are computed monthly and sent to GPs around Scotland. Since 2006, the project has been developed to version 3, which now covers 80% of the Scottish population. We are developing version 4 using cutting-edge machine learning methods to see if we can do better. Next slide, please. We found that modern machine learning methods could substantially improve the accuracy with which we could predict emergencies. If we consider the 50,000 people in Scotland with the highest scores, we would hope to identify a lot of patients who were eventually admitted to hospital. When we use version 4 to do this, instead of version 3, we can identify more than 5,000 additional such individuals. Put another way, if we're to use the score to bring to GP's attention the 1% of the Scottish population most likely to have an admission, version 4 would mean that we can potentially avoid 3,000 more emergencies. We addressed a problem related to general updating of predictive scores. It's impossible to determine in our case whether the poorer performance of version 3 was due to it simply being out of date or due to it working, doctors acting on high-risk people and making them low risk. In other words, version 3 was fitted only to doctors' baseline behaviour, but version 4 was fitted to that plus whatever they were doing with version 3. This means we can't just replace version 3 with version 4. Instead, we have to use version 4 as an adjuvant to version 3. Next slide, please. We looked at how people's risk of emergency hospital admission changed year to year. Looking at scores for the same people for 2 time points a year apart, we found that for people at a low risk, their risk usually increases only very slightly year to year as they get older, but can sometimes suddenly jump to a much higher risk. On the other hand, we found that people at a very high risk usually had their risk go down in subsequent years, although usually not back to normal. This suggests that a high risk of emergency admission is transient. We examined how age affects emergency risk by plotting the contribution of each individual's age to their risk score. We found that risk was high for the very young and rose rapidly for people older than 60, but was largely level in between these ages. Outside of people at the very highest risk, most people's emergency risk remains quite similar over a time span of a few years, so we can use health data collected from before the COVID pandemic to predict emergency risk afterwards, with only a modest loss in predictive accuracy. Final slide, please. Some causes of hospital admission were easier to predict than others. People admitted due to cancer, their hormone system, or lung problems tended to have high risk scores, making them easier to preempt. On the other end, people who were eventually admitted with eye, ear, or skin problems, or trauma, didn't have particularly high scores, indicating that these admissions occur more at random. By breaking down the score by contribution of risk factors, we could compare their importance. We found that the difference between the most and least deprived 10% of the Scottish population generally contributed to emergency risk as much as 20 to 40 additional years of age. It's well established that both deprivation and poor health can cause each other, but this illustration of the extent of the effect is stark. I do not have time to thank everybody involved in this project, but would like to thank our core team, Louis Eslett, Sam Emerson, Sebastian Volmer, Catalina Vejos, and Bilal Mateen. Scotland has some of the best medical record keeping in the world, and this project is unusual in that it is on a population-wide scale and is in clinical use. Because of that, it must remain completely reproducible and transparent in how it works, and we are grateful for the support of an HDR UK grant under this initiative of reproducibility. Thanks very much, and I'll now hand over to Carl.
Good afternoon, and thank you for the opportunity to present today. Based on swine flu, UK government planning predicted that in an influenza-like pandemic, there would be around 750,000 excess emergency department attendances, and that hospitals could be overwhelmed by lower risk patients who required no specific treatment. Next slide, please. In the first wave of COVID, emergency department attendances actually dropped by 25%. This is in part due to displacement of risk assessment of patients with suspected COVID infection to NHS 111 telephone triage services. From the 18th of February, the NHS advised patients with suspected infection to contact NHS 111 and not attend healthcare providers. There were almost 3 million calls in March 2020, a record number and double the number of the previous year. Despite the important role played, there has been no evaluation of the accuracy of the risk assessment provided by these services. We therefore aim to assess whether patients with significant adverse outcomes were provided with an emergency response and identify factors which may improve triage. Next slide, please. To do this, we were provided with a cohort of all callers who contacted Yorkshire Ambulance Service NHS 111 telephone triage between March and June 2020, who were assessed by clinical pathways for suspected COVID infection. As shown on the left, NHS Digital linked these patients to Office for National Statistics death registrations and routinely collected hospital and GP datasets. This allowed us to assess our primary outcome, shown on the right, and provided more detailed clinical information about the callers in our cohort. Our final study population consisted of all callers aged 16 or over who could be traced by NHS Digital with a known triage outcome. The NHS 111 triage assessment outcome was divided into being provided with an ambulance or other urgent clinical assessment, or being advised to self-care or have a non-urgent follow-up. The accuracy of these triage categories for the primary and secondary outcomes was estimated. We used multivariable logistic regression to identify factors associated with either no urgent clinical response to deterioration or an urgent clinical response and no adverse outcome. Next slide, please. Of the 40,261 callers in our cohort, 3% died or required organ support. 60% were advised to self-care or received a non-urgent assessment, and they had a very low 1.3%, but non-negligible risk of subsequent deterioration. The sensitivity and specificity of the telephone triage to the composite primary outcome is shown on the slide, and it is similar to triage pathways used to triage patient acuity in the emergency department and other urgent care settings. Sensitivity of the telephone triage was higher for outcomes at 3 and 7 days. In our multivariable logistic regression analysis to identify predictors of incorrect triage, the importance of comorbidities related to respiratory illness appeared to be overestimated, whilst diabetes was under-recognised. Most strikingly was the association, shown at the bottom, of repeat contact with the service and not being provided with an urgent response and then deteriorating. So to conclude, from our study we now know, 1. Telephone triage was used effectively to divert patients to self-care or for non-urgent clinical assessments, and these patients had a small but non-negligible risk of deterioration and significant adverse outcomes. 2. Performance was similar to methods used to triage patient acuity in other emergency and urgent care settings. And 3. Accuracy of triage may be improved by better recognition of multiple contacts with services as a predictor of adverse outcomes. Our further related research includes evaluating 999 and ambulance crew triage, the results of which I've not had time to present today. Thank you for listening, and I'd like to thank the patients and everyone involved in the pre-study who helped provide these results today. I'll now hand over to the next speaker, who's Claudio.
Many thanks, Carl. Hello, everyone. My name is Claudio Frontera. I'm a lecturer in biostatistics at Lancaster University, and I'm now going to give you an overview of how statistical models can help in giving insights for tracking COVID-19 cases in England at the lower tier local authority level. So at the beginning of this project, we had in mind to integrate publicly available data to build a real-time surveillance system with the aim of tracking the evolution of COVID-19 cases in the country at a fine spatial scale, the LTLA level, and provide short-term forecasts on a weekly basis. And more importantly, being able to give information on possible resurgence and outbreaks within the country. So essentially wanted to being able to detect spatiotemporal hotspots. We also wanted to provide insights that are easily accessible to everyone, actionable, so they can enable implementation of policies in an optimal way, and also easy to interpret. So what we did was to use daily reported COVID-19 cases at LTLA level from Public Health England, along with population census data. And essentially the way our model works to predict future number of cases is within LTLA, we look at the past number of reported cases, and that is a measure of local transmission. But it's also important to look at what is happening in the rest of the countries, because cases can also be imported from outside. And the level of transmission between different areas in the countries depends on the connectivity between these different spatial units. And we include this aspect in our model by using both traffic flow data from the Department of Transport and commuting data from the last census. And this gives an idea of how much people are moving between the country. And we present the outcome of our model through an openly available website that shows an interactive map with the predicted number of cases for every single LTLA. You'll notice different red and blue flags, and especially the red flags indicate those areas for which our model detects a possible resurgence of COVID-19 cases or a potential outbreak. So there is, in those areas, an unusually high number of reported COVID-19 cases. These are results of the 6th of June, and at that time we detected two big clusters, one in the northwest of the country and another one in the London area. And these now are well-known cases of high transmission. We can also then zoom and click on a specific LTLA. In this case, I'm showing Manchester, and this will show the COVID-19 trend of the last 2 months. And especially we can look at the last week, where our model is detecting this anomaly. So this gives important insights, information to local governments to detect promptly those areas that are very high risk or where an outbreak is probably going on. And so they can intervene and they can apply restriction policies in an optimal way. The results of these models are updated daily, and they are provided both to scientific committee like the SPI-M and local governments. I want to thank my colleagues at CHICAS, Chris Jewell and Barry Rollison, with whom I've worked during this project. And thank you very much for listening. I will now hand it over to Daniel.
Thank you, Claudio. Hi, I'm Daniel Thompson, and I'm a data scientist at Swansea University. And I'm going to give you a quick overview of the analysis we did to look at COVID transmission in schools in Wales. So we were tasked with trying to find out whether staff or pupils are more likely to be infected if A, there's a case in their own household, or B, a pupil or staff case in the school, or whether there are household cases of pupils or staffs in the school that they attend. So to answer these questions, we used the SAIL data bank and linked up a number of core SAIL data sets. The two I'm going to highlight today are the SWAC dataset, which is the School Workforce Annual Census, and the Education Data for Wales dataset. We linked these datasets to the COVID-19 C20E cohort, and by linking these datasets, we were able to identify individuals who are pupils and staff members, and also identify the school that they attended. With this cohort, we were also able to link the COVID-19 test results and identify whether one, they'd had a test, or whether they were negative or positive for COVID. So once we had linked up all the data, we created our key cohort, and we were keen to look at pupils and staff members who had had a test between August to December 2020. It was important that they were linked to an educational setting so we could identify the school that they attended, and also that they were linked to a household so that we could identify the household members that they lived with. We had to remove pupils aged 11 or 16 because the educational data set we were using was based on the previous year, so we weren't able to confirm the school that they currently attended. So once we linked that all together, we had around 1,400 schools in Wales, 70,000 pupils, 13,000 staff members, and linked to these pupils and staff members about 70,000 additional household members. So we then performed some logistic regression to determine the odds of a COVID positive outcome between August and December. We were keen at looking at those three exposures I mentioned earlier, and what was interesting is that we took the individual's test date and looked back 14 days within each exposure and counted the number of cases within that exposure of interest. So for example, we counted the number of cases within the own household, and we counted the number of cases within the staff, or we've counted the number of staff or pupil cases within the linked schools. So not just the generic number of pupils, but also if the individual was identified as a pupil, whether there was a case of a pupil in the same year group or a case of a pupil within not in the same year group. We analysed them as a whole, so staff and pupils together, and then also stratified by pupil and staff outcomes. So here are the adjusted odds ratios for our models, and a couple that I want to highlight, mainly how the increased odds of a case within the home of a individual becoming COVID positive, but also the case of pupils, where a case of a pupil in the same year group increased the odds of another pupil within that year group of becoming COVID positive by 12%. So there's a lot of odds ratios to take in there. So interpreting these as a whole, and after adjusting for household cases, we found that staff members were not significantly at increased odds of a COVID positive case after a case detection in the school. However, pupils, we found that there was a significant increase in odds appearing when a case appeared within their own year group. The results indicated that the strong mitigation measures that were used over the whole study period may have reduced the wider spread within the school environment. These results directly informed Welsh Government's COVID-19 Technical Advisor Group, which fed into SAGE, and in Wales actually helped inform decision-making around school openings following their prolonged school closures during the lockdowns. So this work was part of quite a large group, and I'd like to say thanks to Hoda, who was an additional first author on this project, along with a number of colleagues. Thanks to those who provided data within the cell data bank and the funding that we received to pursue this work. Thank you very much. That's all. Thank you.
Thank you very much, Dan. And wow, what a 20-minute. Thank you very much. Fantastic pieces, Yelena, on the UK Biobank COVID serology study, James on predicting emergency admission in the Scottish population, Carl on assessment of how accurately telephone triage service identified those at highest risk or with adverse outcomes, Claudia on the spatial time series modeling approach for tracking the COVID-19 cases, and Daniel on the likelihood of COVID-19 test positivity in schools and pupil and staffs. So please do ensure to submit your votes before leaving the session. There will be a voting now appearing on the right-hand side of your screen. We will be announcing the winner at the end of the day, so don't wander too far. And if you are like myself, the talks have sparked your curiosity and have many questions, please go ahead and post them on the Twitter page for the presenters. Thank you very much all.